Kibet. What do you think if a hemophilia treatment center would like to start a prophylaxis program? What are the infrastructures and logistics you need to start such a program?
Thank you, Dr. Magdy. I come from a setup where factor concentrates have not been readily available. Through the humanitarian aid program to Africa, we now have factors that are readily available to our patients. And so other than just treating children or adults on demand, we have started a prophylaxis program. To be able to effectively provide prophylaxis to our children, one of the things that one has to do, or we had to do, was to make sure we had, a hemophilia comprehensive care clinic where patients would, come and be attended to. We had to make sure we had the appropriate personnel trained on, the dosing that would be given to the child, the frequency, and possibly at a bare minimum try to understand the basic things that we use to evaluate the child's performance. We also have had to identify families or children whose parents are willing to work with the program, because that is key to any successful prophylaxis activity. So we had to start in a small way. We didn't have to open prophylaxis to every other family. We had to identify or determine a criteria that we could use, and part of that criteria was the distance of the family from the hemophilia comprehensive care clinic, the willingness of the parents to bring the children for prophylaxis, and also their willingness to escalate or use other more improved mechanisms of providing the factor to the children. Initially, we've been using the usual infusions by identifying the veins. But we noted that because of the frequency, some children became a little difficult, so we've gone ahead to initiate insertions of portacards.
Okay, thank you.
And so that is really helpful to us in terms of administering the factors. And we are now training the parents on how to administer this. The other activity around prophylaxis is if a family is willing to either identify with a nearby facility to either continue prophylaxis from there, or if the family has capacity to administer the prophylaxis wherever they are, then we create a framework that can accommodate that as well, so that at least we don't interfere with the lifestyles of the parents and the patients to the extent that then they're unable to have a normal life.
First of all, the number of injections per week, it will be tailored according to different patients, their activities, the level of education. So we'll start once. If we need more than once, it will be twice. And if we need more, it will be 3 times a week. The monitoring is very important. And the involvement of a multidisciplinary team is also very important. We need engaged person. Physiotherapy is very important for the outcome assessment. Nurses is very important. Social worker, and I mean we don't have social worker, but we do all together, the physician, the nurse, the physiotherapist, in order to educate patient and families. Education is very, very important, and patients have to understand how prophylaxis works in order also to control the different activities. So I think that all the countries with limited economic resources could do it. The only thing that is important is involvement of a team, of a multidisciplinary team, to have the better results for that.
So I will go to Dr. Günter, since he has a long experience with this, and I will ask him if things like a laboratory facility and a registry in the center has a value in establishing such a program.
So we know now that about 50 or more than 50% of persons with severe or with hemophilia are not diagnosed at birth because we have no family history. So usually these children will be diagnosed between 6 and 12 months if you have a good lab, which is extremely necessary that you can measure factor 8 and factor 9 exactly. If this is not possible, like in small hospitals, you may have a reference center in the country where you can do this diagnosis.
So in your center, when you diagnose new patients, how many of them are severe, how many of them are moderate, and how many of them are mild?
If we are talking about hemophilia A, again, the majority of them will be severe. In the case of hemophilia B, maybe moderate or mild hemophilia could be most frequent than severe. It is important, as you say, to define and classify from the very beginning the severity of the hemophilia, because with this diagnosis we are going to decide whether the child will begin a primary prophylaxis or not. It is, first of all, very important to, as physicians and treaters of patients with hemophilia, that we should be convinced that primary prophylaxis, even with low dose, is the best option of treatment for people with severe hemophilia. Then, if we are convinced, we can encourage families to decide and to take this as the best option for their children.
Between 20 and 30% of persons with hemophilia will develop inhibitors. And these inhibitors are, as the name is said, inhibit the factor 8 and therefore make the therapy on demand and prophylactic therapy very much more difficult. So it's also necessary to have a good lab that can measure inhibitors. If you have no really inhibitor tests, it's quite easy to make a mixture of your tests and you can also detect an inhibitor. Then you don't know the exact Bethesda units, but then if you have this, you need to send the blood to a lab that can do it. And inhibitors are very stable, so you can do it, send it by post. Even, I think, in the temperatures of Africa, you can do it and you can measure it. That is very important. You should know what happens to your patients. If you are alone and you have maybe a big center and have maybe 5 new severe hemophiliacs per year, and you have an incidence of inhibitors like in hemophilia of 30%, you need many years to detect these. So it's much better to have a registry work together with other centers and make a registry of your patients, and then you can see how many inhibitors do I have, how many severe hemophilias do I have. Maybe I can do some gene diagnostics and can see whether a special mutation in my community or my country plays a role for the development of inhibitors.
I think it was a very good opportunity that we have these distinguished panelists with various experiences from different regions of the world. We hope that this will convey to our community the value of the prophylaxis and give them an inspiration of what they need to do in their communities. Thank you very much.